reviewing your CV. Because
Thanks for coming.
Sorry.
It's our pleasure.
Would you like me to sit down?
Sit down. Our informal grand rounds in geriatric. Dr. Kendall Cornu, who we recruited about, when did you start? July?
Started July 1.
July 1. As his palliative care training from Vanderbilt. And before that, I forgot, where were you before Vanderbilt?
Well, I did my internal medicine residency as well as a year of hospitalist work. And then I spent a year in England starting my PhD.
Nottingham.
The Nottingham of Nottingham Forest.
Yeah.
Robin Hood.
And so he is part-time in general internal medicine, and the majority of his time is in ethics. I get that department right?
The Center for Healthcare Ethics, just down the street.
All right, so we expect
Recording's on.
and we'll go ahead and get started.
Well, I wanted to thank Julie Gammon, who's just not here, for inviting me to give this. So this is a mouthful title, but it's mostly going to be cases with some explanation in between. No disclosures. So I'm going to kind of give an overview of how I present what palliative care even is. What is ethics? I realize these are like Socrates kinds of questions. What is medicine? What is palliative care? But I think just getting common definitions in place are going to be helpful. Then how does palliative care and ethics relate to one another? Explore that question. And then go through some cases, difficult goals of care, what geriatricians always face, loss of autonomy, what that means. And then, if we have time, palliative sedation, which I don't know if any of you had any experience with that. So the first case, difficult goals of care. This is actually a patient I saw when I was first on service here, on the palliative care service. 74-year-old lady, had diastolic dysfunction, heart disease, AFib, valvulopathy, kidney disease. We came in with volume overload. She'd been having recurrent pleural effusions while she was in the hospital. Her effusions were shown to be exudative, but she was requiring several thoracenteses to remove the reaccumulation of fluid. Also important to note is she was just in the hospital a month prior, and she was intubated because of respiratory failure, thought to be due to volume overload. Also had failure to thrive. She didn't want to eat. She had poor appetite. Wasn't eating for, as she would say, the past several months. Her albumin was less than 2.5, and she was very cachectic. She weighed 80 pounds, and you could see it from the door. And she really didn't want to do things like artificial nutrition, NG tube, drop-off tube, surely not a G tube. She just did not want to go there. But her husband's always at her side. He's the devoted husband, but he's a very, how shall I say, strong advocate for her. He would always run any conversation with the medical team. And when we finally got the consult, she had already been in the hospital for a week. And I'd always gotten told before going in, watch out for the husband. Like, it was just one of those hot potato kind of patients, like no one wants to talk to them because it's been so difficult. So what do we do about this difficult situation? She's been here for a week. She's refused, she's tried NG tubes, they haven't worked. Now she's kind of stuck in the hospital with this kind of domineering husband. I want to talk through kind of my philosophy of medicine to just kind of contextualize how we even think about goals of care. So Edmund Pellegrino, he died in 2013, but he was a giant in bioethics, also an internist. He was president of Catholic University in the 80s, the first layperson to be such. And I think he kind of single-handedly resurrected philosophy of medicine. And what he means by philosophy of medicine is not deontological theory, consequentialist theory applied to medicine. It was going back to what it is that we do in medicine. And for him, it's the relationship between the physician and the patient. I mean, these things seem a little obvious and self-evident to clinicians, but in the ethical bioethics community, this was pretty groundbreaking, actually. So for him, it's a relationship. you have a patient on the gurney. That's the way he would describe it. Vulnerable, needy. Patient has this lived experience of illness. I hurt. I'm confused. I'm scared. The physician has training to bring about healing and has a duty to bring about healing. And so the physician-patient relationship is the meeting place for what he would call a practice. Practice is activity that has an internal goal, and for medicine, it's the goal of health. And for him, the only way to make sense of bioethics is to contextualize it within this physician-patient relationship. It's not this top-down approach where you have these philosophical ideas and you just impose it upon medicine, which is deemed to be this amoral thing. No, quite the contrary, medicine intrinsically is a moral activity. Now, I think you would probably agree that that seems pretty obvious, but the way that we train medical students and residents, I don't think we use that kind of language, honestly. But I think intuitively we would think that that seems to make sense. So to broaden this even further, I want to make a distinction. I stole this slide from a former colleague at Vanderbilt. Distinguishing between, on the right side, this is what you would find in kind of the canon of biomedical ethics, the 4 principles. But this is when you need an ethics council where it's, this dilemma. Autonomy, beneficence, non-maleficence, and justice. But this is where I think Pellegrino would say this is where the heart of medicine is. This is where every day we're dealing with ethics. Because we're partnering with our patients to figure out how do we best bring about health. The physician showing compassion in the presence of the patient's vulnerability, the patient on the gurney. How do we treat them well? This is an ethical practice. How do we engender trust? It's not merely a skill, but it's an ethical practice. And then talking with the patient, how do we discern together? How do we make your life better? Or how do we make your dying easier? So this is every day. This is what makes possible to even have these kinds of conversations. Now I want to introduce another concept called microethics. There's not a ton written about this, but like the previous thing, it's kind of like 2 buckets. Macroethics would be the 4 principles again. But it's kind of abstract, theoretical, it's applied on top of the clinical encounter. But I think this notion of microethics is the clinical encounter, is the source, the context for any ethical practice, ethical action. And what I mean by this series of microethical moments, it would be how you sit down next to the patient, the tone of voice that you use. An example being informed consent. How you do the informed consent. There's embedded ethical questions. How much do you say? How much do you not say? Because we have values that we bring to the table as well. We're not mere service providers, although that's the way healthcare economics talks about physicians. But we're one party of a 2-party relationship. And so there's this interpretive dance that occurs between the 2. And through this kind of conversation and this relationship, particularly in difficult moments, we're helping elucidate values. We need to be aware of our own values, and then, based upon what the patient tells us, try to figure out what their values are. Because they may not even be able to articulate it when asked, do you want to have this? Do you want to have that? I don't know. This is the first time I've heard of those things. But what is most important to you? This is something that is worked out within the clinical encounter. And then it's concrete. So this is pretty self-evident. We're not just imposing things upon the clinical encounter. The clinical encounter is where we find ethical moments. So a key point I want to drive home is clinical medicine and effectively communicating with our patients. This is ethical practice. It's not needing an ethics council. That's not this ancillary thing. It's embedded within the practice itself. I just wanted to share this cartoon because it shows how the life worlds of a physician and a patient can be very different. The doctor's about to go play golf and the patient's lugging around his oxygen the whole time. And that's going to dictate how we have conversations about things, what's most important to you. Because their experience is going to be different than ours. And they're coming on our terms all the time, to the office, they're in a nursing home, they're in the hospital, and we need to be sensitive to that. So how we address that power asymmetry is an ethical practice. So then, now focusing in on what is palliative care. This is the WHO definition. I just want to highlight a few things. It's about quality of life. Not that quantity isn't important, but the focus being quality. That it's the patient and the family. So it's a multi-sourced unit, not just merely the patient. When they're facing a life-threatening illness, so it doesn't have to be life-limiting purely. So you don't have to be terminal for palliative care. And the goal is to relieve suffering in a multi-orbed kind of way, not just physical, but psychosocial, spiritual. There can be some danger in conceiving palliative care this big, because that means medicine has a lot of power to define things. I don't think it necessarily has to be that way, but I think that's one tendency. But that can be left for questions later. So another way to put it, it's multidisciplinary, because we're talking about the whole person. Yes, palliative care doctors, we deal with pain, nausea, constipation, but how those symptoms are experienced. That's where we need chaplains, that's where we need social workers, nurses, to work together to make sure that every part of the patient in their totality is addressed. So when is the right time to call for a palliative care doctor? Is it, oh, the patient just got this stage 4 cancer diagnosis and it's in the brain and they don't want treatment. Palliative care should be consulted. Well, not quite. I think you could easily make a case for earlier intervention. So the indications for palliative care. Wow.
Hi, yes. We had a different one, sorry.
So what are the indications for palliative care? And these 3 dimensions is what I actually tell patients and families, because the first question I ask my patients when I see them is, do you know what palliative care is? And 90% of the time they've never heard of it. And when they have heard of it, they think it equals hospice. And so this is what I tried to, I use this language to dissuade them of that, to distinguish the two. And so I start with goals of care. I don't necessarily use that terminology with the patient, but another way that I explain it is making sense of what is most important to the patient and seeing if that's consistent with the medical treatments that are available. And so this requires a lot of conversation. Who is this patient in front of me? Knowing what their values are. Asking things like, how did you meet your spouse? Because you learn a lot of things that way. What has life been like the past year, the past 6 months, the past 3 months? So the patient gets some insight into how are they really doing, because they may not have that kind of insight. We often, unfortunately, have to break bad news, because maybe the oncology team did tell the patient, but it was presented in such a way that it's like, yeah, they said all this stuff, but I have no idea what they just said. So I try to bring down the language to a level that's understandable. And then navigating treatment options. I do give recommendations, but that's based on after I know what the patient is. But I explain what the options are and how each one could be consistent or not consistent with their particular values. And then maybe if it was an early palliative care consult, do advanced care planning. We don't need to deal with hospice, we don't even deal with a lot of pain medication, but if they haven't thought about this, that's a way that we can help. And then elucidating values. Like I said earlier, sometimes patients have really no idea what they would want to do. And just asking them, well, do you want a feeding tube or not? Well, I think we need to probe a little bit deeper. What do you envision life to be like? And how would this be consistent with that vision? And at times, we want to offer hope, because sometimes they say, oh, I got this cancer diagnosis, doc, I'm going to throw in the towel. And say, no, actually, you can still live life well with the life that you have remaining. And we don't know how much time that is. And sometimes that means being realistic. Say, doc, we're going to beat this, I know for sure. Say, okay, but when I see patients like you, this is what I see. So that I want to give them as much that I can in terms of what I've seen before in my experience in this relationship. Another thing that we can do, pain and symptom management, that's pretty self-evident. And then I sometimes mention hospice referral, not always when I'm explaining it to patients, because it might not be the right thing to do. So I just want to emphasize goals of care that's kind of how I organize, how I think about palliative care, is because it's really, language I also use is advocacy for the patient, advocacy for the family, because I'm not trying to necessarily impose my own values, but knowing that I have values too, and to help elucidate for them. And that would help elucidate then how do we approach pain and symptom management. Yes?
When palliative care first sees a patient, at least on the inpatient service, you're a consultant. Okay, and so there's some expectation between you and the consulting team about what it is they want from you.
Sure.
So that our data from here, when we take a look at when do they call palliative care, in terms of what do they want from us, it varies somewhat by which service is asking the question. So the most common question is to clarify goals of care. The next most common question that's it, and we have all the printouts Patty has in the is help with symptom management. And the third most common reason is to say, is this patient eligible for hospice? And so those are the three things that they ask for in the descending order of frequency.
Yes.
So, I mean, it's just, they seem to already know it.
No, sure. But I will say, though, that there are times when something is just put in, but it's not really a question per se. Stage 4 cancer. Well,
please consult.
Yeah, well, what's the question?
Yes, what's the question?
Because I think, we are trained in the hospital to ask more physiologic type questions, but how to do it in something that's a little more impressionistic. Sometimes it's put in the consult request, difficult family member or something, and help us with that. But oftentimes I have no idea what the question is.
That was actually not as common as you'd expect.
Well, I mean, maybe it's the times when I don't see a question that it means a lot more existentially for me, and I get really frustrated with that. But I don't actually know the numbers. So the key point that I want to just drive home is, in every part of goals of care, pain and symptom management, hospice referral, there's effective communication within this embedded relationship. This is practicing ethics. In other words, palliative care as ethical practice. And I don't mean that only palliative care does this, but as a more focused way of thinking about it. I think any clinical medicine is going to be ethics. So back to the case of the 74-year-old lady who's stuck in the hospital, cachectic, not wanting any feeding tubes, and she has recurrent pleural effusions, and she has a domineering husband. What do you do about that? So I went into this family meeting, where I went into the room really to meet the patient for the first time. I wasn't sure if the husband would be there, but after hearing about him, I was pretty sure he would be at the bedside, and sure enough he was. He was reading his Bible. I don't remember exactly where in the Bible he was reading it, but he was reading very intently. He was highlighting things. And I tried starting a conversation with the patient, and immediately the husband would speak. I would do this very simple model, ask, tell, ask. Ask the patient, what is your understanding of what's going on here? How are you feeling? How are you doing? Do you even know what we're here for? Are we helping you at all? Any of those kinds of questions the husband would answer for her. And so I would try to tell back to him, well, here's what we're doing. And then I would push when he would not relent. I'd say, okay, let's see, because your wife is actually nodding her head. What does she actually say about these things? And he didn't like that. But I insisted. in as gentle a way as I could, and I was holding her hand when I did it, and sitting at the bedside. And I asked her, "Are you feeling that good?" "No." "What do you want to do?" "I want to go home." "Do you want this feeding tube?" "No, I don't want that." And he would say things like, "She needs to eat. I have to get her to eat. She needs nutrition. I need her to have nutrition." And patient, do you want any food? No. Does any food sound good to you? No. It was pretty clear that she wasn't going to have any of that. She'd already tried this thing in her nose, and that wasn't happening for her either. But it was pretty tense in there. But at least I got her to say things on her own behalf, which apparently hadn't been happening in the hospital because the husband was always running things.
When did anybody ask the husband what he needed?
Well, I was able to tell some of that by his responses.
You were assuming based on what he said, but you didn't ask with him.
I'm going to get to that. I just wanted her to be able to speak because she hadn't been speaking. So we had a second family meeting, or at least second encounter. So this was on a Friday, and this was on a Monday. So I did ask till ask with both of them. And after thinking a little bit more about what was going on with her medically and talking with the cardiology team, it was pretty clear to me that, and after the psychiatry had evaluated for depression, and cardiac cachexia was a pretty big, number one on the differential. And given her low albumin, given her food aversion, her weight loss, it's like, this is what's going on here. Cardiac cachexia, and that's a very poor prognosis. It was a little unusual that it was diastolic dysfunction, but other things have been ruled out. And so given that, I was trying to explain to the husband, because I asked him, what do you see happening with her? What have you been seeing? And he said, well, she hasn't been eating and she needs to eat. And I asked him, have you asked her why? He really didn't have much of an answer. He just assumed that she needs to. And so I explained a little more medically what was going on. This cardiac cachexia, we're not talking about years, we're talking about months here. And I did ask, is that even something we should talk about? And they said, yeah, we want to know those things. And so I explained what was going on with her body, and that the attempts at physical therapy, that was a big deal because she couldn't get out of bed. She'd been in the hospital for, at this point, a week and a half. And artificial nutrition, or at least appetite stimulation. And that wouldn't overcome the physiologic process that was already occurring. And so he just said, so you mean, Doc, what you're trying to say is if we get her to eat and do physical therapy, that's not going to fix her? And so I'm sorry to say that no. And that's immediately when he started crying. Because he knew that was what was happening, but he didn't want to believe that's my interpretation, that what was happening. And then he said to her, and I remember very vividly, you don't need to work anymore, honey. We'll go home. And she said she just wanted to go home. She wanted to die at home. He didn't want her to die at home because he couldn't handle the emotion of that. But she eventually got a Pleurex catheter for the recurrent pleural effusion. And she was eventually discharged 2 weeks after admission. But she died 1 week after she was discharged. I just happened to chart check as I was going to present. I was like, wow. I knew she wasn't going to live very long, but that really blew me away. And it just shows that none of us are very good at prognosing things, or at least I'm not. It's a very humbling practice. So, how accurate are physicians? Some of you probably know this study already. But Christakis in 2000 about how accurate are we? University of Chicago looked at 5 different hospices in the Chicago area, and they would follow up with the doctors and the patients about how long did they live and how long did the doctors think that they had to live? Well, it showed that the patients lived for about 24 days after discharge to hospice, which is actually much longer than what we find in the CMS data. Only 20% of the predictions were accurate, and an accurate prediction is if you get within 33% of their actual death. So that means with a median survival of 24 days, they were off by over a week in their prediction. 63% were overly optimistic, and 17% were too pessimistic. And so some of the conclusions they've made based upon the characteristics of the physicians is that regardless of specialty, we seem to overestimate life expectancy, and I surely did that for our patient. The better the patient knows, the better a doctor knows their patient, particularly in a context of physician-patient relationship, they're more likely to err in prognosis on the optimistic side, which you could call optimistic bias. And physicians that are more experienced are more likely to make accurate predictions. All right, so the second case, loss of autonomy, and you geriatricians have a lot more experience with this than I do, but Julie Gamick thought it would be nice if I just gave my thoughts on this as well. So we have a 93-year-old man, had a history of bladder cancer, but he wasn't getting actively treated. It wasn't a problem currently. He came in with failure to thrive and weakness. Interestingly, he had been working as a car salesman this whole time since before World War II. He first sold a Studebaker. He fought in World War II. Continued to be a car salesman. But over the past 3 months, he lost 40 pounds. And he looked very gaunt. Just initial evaluation when he was admitted showed pulmonary nodules. Didn't get a CT scan. Because he had already said he wouldn't want biopsy, he wouldn't want chemotherapy, even if chemo would be an option. So he had been working up until 1 week prior to admission. And it was because the people at work said, "We love you, but..." Because he was like losing his sight and I mean, it was bad. Just rest. You need to take care of yourself. We love you, but take care of yourself. He lives with his 85-year-old wife who has her own medical problems. She has back pain and can't stand for very long, kind of weak. Well, after talking through, we think that this failure to thrive is due to this probably recurrence of the bladder cancer. It could be a secondary, a new primary. Regardless, it doesn't look good. So he said, okay, hospice sounds good to me because I don't want aggressive care and I just want to maximize the life that I have. But he insisted on going home. And I'd ask him about that. Oh, well, I want to go home and, wash my cars. Take care of them. Clean up the garage a little bit. I thought, okay, well, maybe he's stronger than everyone has been saying. And of course, I called the wife. She's like, oh, no. He hasn't been able to do anything for the past 3 months. So what do? He's really weak. He's got this frail wife at home, and he's insisting on going home with hospice. What do we do about that?
Jim, home with hospice and let hospice wash his cars.
Try to be in there to take care of them.
Don't wash the cars. Wash the cars. It's your last wish.
Call the daughter.
Make sure there's no gun.
Yeah.
So what would be my autonomy? Because we're talking about loss of autonomy. And
Wish foundation.
I think you are all experienced with making this difference about, well, autonomy, at least understood in the bioethics literature, is kind of from this liberal philosophy. Liberal in terms of being autonomous and being able to, we are unto ourselves, individual. So then issues of decision-making capacity, cognitive function. If you don't have those things and you lack autonomy, can you be independent, physically, mentally, do things on your own? Well, that's one dimension of autonomy, I think, but another concept of relational autonomy, that what it means to be who we are as individuals is always in the sense of we're interrelational. How we make sense of ourselves is always in relation to other people. Even if we're hermits, we've chosen to not associate with other people, and that kind of defines who we are. And being interdependent. I'm functional, but I'm dependent on my wife to kind of be who I am. And that it's always situational and contextual. I mean, to be able to make choices in the hospital even, it's confined by the situation and the context of what medical bureaucracy can provide, how our bodies are doing, what our finances can pay for. So I just want to highlight a different way of conceiving autonomy that, again, is probably intuitive, but just wanted to make it explicit so that we're not always running into these different principles of autonomy versus beneficence or something. So getting back to the case of the 93-year-old man, so I had a family meeting with the wife and the daughter. And of course, the wife, she's sitting in her wheelchair because she's not able to stand or anything like that. And the daughter, who seemed very aware of the issues, but wanted to honor her dad. So I let the patient speak and share his concerns, talked about what he would want, and it was sounding like he wanted his wife to do what his wife was always doing: cook for him, clean up after him while he did his hobbies. And then I let the wife and the daughter speak. And here's the wife, and she didn't say a whole lot. I had to extract things from her because she didn't really want to say that it would be really hard to take him back home, and take care of him. They wanted to have that said. And then I wanted to paint a picture of what would be the case. Okay, let's see if you went home. Here's what could be provided. He was a vet, so he had VA benefits, but even with home health services on top of home hospice, 5 hours contact at home. So it would require the daughter to move in because the wife couldn't take care. But that's what that option would look like. And the patient still,
if these ages are correct, the daughter herself is close to 70.
yes.
Where's the grandson?
There isn't in this story.
Always live in California.
And then also, because he was a vet, we also had the option of the inpatient hospice unit down the road. Well, 45 minutes down the road, but down the road. But it was close to home, relatively speaking. And then maybe nursing home with hospice options. And the patient still said, going home sounds really good. And I had to ask the wife again, does this sound like a good plan to you? And she said no. And so I just had to let her say to him that this is going to be really hard if you do this. And after much more time together, we agreed on getting him to inpatient hospice at the VA because it was close to home. And I used the language of, you can let your wife be a wife and not a nurse. And she didn't feel like she was capable of giving that to him. And the next rotation, this is during my fellowship training, the next rotation I was at the VA inpatient hospice. He was actually doing pretty well in the hospice. So he seemed happy and not needing to wash cars. So it turned out well. But if he had gone home, I would have said, here's our number. Call if this doesn't work out. And,
Well, but we run into a plan C a lot of times.
Sure.
Which is to mollify the old guy or the old lady about wanting to go home when it's pretty clear they're not going to go home. So go to the nursing home and get a little rehab and get stronger, and then you'll come home. And they'll always agree to that. And then at the receiving end, at the nursing home, you have them taking sometimes these moribund persons and dragging them out of bed to do rehab, and often being yelled at if they won't cooperate. And much of the time there's no one there who can have this conversation with anybody. So what's your strategy with, I know you're dying of cancer, but we just want her to have a little rehab and get stronger and then come home and die on hospice.
So I guess I would go with plan D, knowing that they're probably not going home, period. So, I mean, in this situation, the physical therapist was like, he's not doing anything, he's not rehabbable. So he wasn't going to escape. But assume that at least he could, possibly get stronger, knowing that he's going to decline. I would say tell the wife, tell him, have our social worker call, like remind ourselves to continue to follow up, or have them follow up when this doesn't work, so that they're not left in the SNF trying to figure out, okay, we have this patient who's getting kind of Medicare paid nursing home care, but after 21 days, what do we do? So always continuing the relationship even outside of the show.
So, do you err on the side of preserving patient autonomy? I mean, within the past 2 weeks, we've had at least 2 cases where, unlike this one, I mean, they lived alone, and neither was terminal. One was practically manhandled into submission, and one was on 96-hour hold, simply because, just like this guy, the insight or decision-making capacity was being questioned.
So, well, in this particular case, I think he had decision-making capacity. He just didn't have insight into his own abilities.
So if that was the case, that insight is being questioned, and then the patient is completely by himself, no family, or estranged from family, I mean, which way would you go? Would you go with...
Well, but I mean, by definition, if they don't have decision-making capacity, then, they don't have autonomy in the sense that they can make decisions for themselves. If that's the kind of, if this is the definition of autonomy we're going to use.
Yeah, but there's a concept of narrative ethics, which is, if this is somebody who has continued to make these kinds of poor choices all their life, that is their autonomy. Even if it isn't anything we would not do, or anything anybody we regard as reasonable would do.
Well, so that's where I want to make the difference between, decision-making capacity in terms of if they can at least make some sense of what their choice means, like I'm going to be alone and I could fall or whatever. Okay, but that's where we would get that part of decision-making capacity evaluated. But we don't have to agree with the kinds of decisions that people make, as long as they're able to get to the reason for that decision. We don't have to agree with the reasons, though. So that I would make that distinguishing remark. But if we think that is a bad idea, but they have decision-making capacity, then I'll say, we'll try it, and that's fine. Or if it's pretty clear, like from the day they were born to now, it's been consistent. Yeah, sure. I'll say, we'll get you home.
Sometimes it's difficult to establish, especially if this is the first time we're seeing this patient and there's really no one else to turn to.
Well, then I think we would need more people involved. That's where I think an ethics consultant would be helpful. At least trying to vet someone who does know this person. When no one is around, I don't have good answers for that. I think it's a case-by-case issue at that point.
I think that's where it becomes our fear even more, because we say, okay, I don't feel comfortable sending them home, because I know something's bad, and they're going to come back in here, and then we're going to see the same problem. We bring it, I think, make it our problem, which it is. It's partly our responsibility. But you're right. That's where, even though you can feel like comfortable ethics-wise in a textbook,
but it feels
you don't
bad.
feel personally comfortable with your own morals. Maybe.
No, I know.
Yeah.
What's morally permissible doesn't always seem to feel like the right thing to do. Like in the patient who's going to be self-destructive. We deal with this all the time in the hospital, the addict or whatever. Those kinds of cases would be beyond the scope of this, I think, because we could spend a whole day talking about those kinds of patients. But I would just go back to, we needed to know who the patient is and get as much as we can, and not just make assumptions. Palliative sedation,
That'd be useful. Yeah. We've all done it, one way or the other.
So a 65-year-old man, metastatic prostate cancer. He came in with lower extremity weakness, found to have cord compression, neurological deficits, having numbness in his lower extremities, that kind of thing. He was having failure to thrive as well, pain in his back, persistent fecal incontinence, had a UTI that was treated, but he also had hematuria, urology was involved, and he couldn't get up. He was in bed the whole time, and he was in our palliative care unit. He was getting a dilated PCA, he had some control. We were hoping to, get all these things tidied up so that he could get to a nursing home or some kind of place out of the hospital. But these complications just continued to rear their ugly heads, and so he remained in our palliative care unit. And he'd been here for about a month after talking to and he had been declining pretty quickly, so we thought prognostically he didn't have that long with us. So we had even told the patient and the family, this is probably going to go fairly quick. I mean, we can say days to weeks maybe, but he was pretty rock solid for this month. But he was waxing and waning, but mostly he could have some kind of consciousness. But he continued needing to be moved because of his fecal incontinence. And when he would get moved, he would have pain. I mean, you get the idea. So he was asking, I just want to go to sleep. This is too much. While the family is paying vigil. So what do we do? Okay, palliative sedation. What do we mean by this? Well, if you read the literature, it's all over the place. There's not a accepted definition even. Palliative sedation, terminal sedation, sedation in the imminently dying. Is it palliative sedation to unconsciousness? Is it proportionate palliative sedation? I mean, and there's guidelines from multiple countries, multiple organizations within the U.S. that don't have a unified definition of what this means. And because there's differing conceptions of what's acceptable and isn't acceptable. I mean, notably physician-assisted suicide or euthanasia, and what we think about that. Proportionate palliative sedation is, I think, in my mind, most helpful because the goal is treating the physical symptoms and just escalating, titrating until that symptom has been treated. Now, at times, that means that they need to be sedated in order to get that particular symptom treated, whether it be delirium, seizures, pain, dyspnea. These would be common things. But the key is without intending to hasten death. Because if you intend to hasten their death, we're getting into different kind of moral territory. So there's legal support for this in Vacco v. Quill in 97. In that court decision, right to die was not a constitutional right. But Sandra Day O'Connor did say if a patient is suffering from a terminal illness, who has great pain, the medication can lead to unconsciousness and hasten death, but that would be permissible because the intent is not hastening their death, but to treat their great pain. The moral justification rule of double effect comes out of Catholic theology. So if you have an action with two possible effects, one good or one bad, it can be okay if this action is not in itself immoral, like giving morphine or benzos or something like that. If it's undertaken with only the intention of getting the possible good effect, i.e. quelling the symptom, without intending the bad effect, although you might see it down the road, like they might die sooner. A key point is 3, that you're not intending, you don't use the bad effect to bring about the good effect. So if someone is saying, I'm suffering, you don't kill the person to bring about ending their suffering. That would violate the third part of the double effect. And that is undertaken for a proportionally great reason. So this patient is terminally ill, they're maybe imminently dying, and we need to get relief for them, for this particular pain or delirium. Some caveats. If you don't think that intentionally hastening death is a bad thing, then you don't need to use double effect. You just say, we'll hasten their death and relieve their suffering. That's okay. but there's a lot of people that would say that's not okay. And then just to say relief of suffering is the intention is a little too broad, because if you want to terminate suffering or eliminate suffering, then you eliminate the person. That would, I mean, that's 100% effective. But so I would, instead of relief of suffering, you'd want to treat their specific symptom. So some controversies that come out of the literature. I mean, how do we define it? Is it just proportion? Is your intention to get them to unconsciousness, or do you want to escalate or titrate? Do we use it for existential distress? I think of a 30-year-old man who has 2 kids, and he went in for AML, got a bone marrow transplant, and he had really bad graft versus host disease of his gut. He was so weak he couldn't get out of bed, and he kept stooling himself. And he said, "I'm done. Stop my immunosuppression and put me to sleep." We stopped his immunosuppression and he eventually died, but that was a tough one. And he was 30, and so he had his blanket with the pictures of his kids on the blanket in the room. I mean, it still haunts me just thinking about that case. But is this intentionally hastening death when you do that for that guy? Or, I mean, do we sedate them for that because they ask you to? I mean, this is debated in the literature, but I mean, do you stop artificial nutrition and hydration? I mean,
In this literature, does the term let nature take its course, does that ever come in? Because, 100 years ago, we didn't have all this technology to do what we're doing now. We have some of it. So if we were living 100 years ago, we might not have as many tough controversies.
No, I think technology in all of its forms generates new questions and generates new dilemmas. But no, nature taking its course. It doesn't really come out. And even when we use that in talking with our patients, let nature take its course, at least that kind of phraseology, it's a little, I mean, when I say it, I kind of cringe myself because I realize, but getting to the patient to this particular point and then saying let nature take its course has required a lot of culture to get there. So then removing the culture is that nature taking its course. So there's philosophy of science and sociology of science that says this distinction between nature and culture is actually a little too discrete, and actually there's a lot of blurring. So that's why that kind of language isn't used in literature.
Our patients don't do the philosophy and they don't do the sociology, and in our population the word natural means something very specific.
No, I understand.
It means something very, very specific.
No, I use it. I'm not saying I don't use it. I think that's why it wouldn't be used in the literature. So.
But natural isn't the same thing as let nature take its course. There's a subtle but real semantic difference.
Letting the disease
take
its course.
Well, killing versus letting die, yeah. I mean, so if you were to remove the ventilator, some ethicists say you have been the proximal cause of killing somebody, but the more traditional moral reasoning is the disease is what ultimately kills the patient. So, I mean, we can quibble about semantics later, but I mean, your point's well taken.
I'm not saying that, I'm not making an argument that it is something different. What I'm saying is, in the language of our, in particular, African American patients, that word means something very specific to them that doesn't necessarily mean to white people.
Fair enough.
Okay, and if you use it properly, you can channel into their feelings about what's going on.
And that's where I go back to the effective communication, the clinical relationship is the source of ethics. Because I want to probe, like, what do you understand about all this stuff? If I'm able to probe. Now, if they're, unable to communicate, then that's a moot point. But I mean, to talk through all of these different things and not just assume that you know what you're talking about or what they're talking about. It's always kind of this dialogical thing. So back to our case. Before we even did something like palliative sedation, he became unconscious and eventually coded and died. Like, we didn't code him, but cardiopulmonary arrest. But what about his intractable diarrhea? Yes?
The Catholic moral teaching gives you an out. It basically says that if it's financially too burdensome, or emotionally or physically too burdensome, the patient can say, this is enough, I don't want anymore. And it's okay.
But it kind of depends on which priest we're talking.
Well, no, reasonable people.
Reasonable.
Come on, Jerry.
Okay.
Which 20% are we talking about?
In terms of burden, the burden,
I agree with you. We agree with you.
Burdensome, yeah. I think burdensome.
like the diarrhea, that's terribly burdensome.
Probably a lot of cramping, diarrhea.
But I just wanted to point this out. So recently there was a review of all of the guidelines, position statements that have been produced since 2002 on palliative sedation. And this particular situation where sedation is not relieving the symptom itself, but decreasing the awareness of the symptom, that's not even mentioned in our guidelines and statements. So this paper just calls for, we need to clarify what we're talking about. Now, is it even possible? That's another kind of question, but there's not agreement across the board. So there'll be cultural differences within institutions, within systems. So just final thoughts, just emphasizing, underscoring things. You're practicing medicine, you're practicing ethics. Palliative care is ethics in particular capacity, and as physicians, we all do ethics. Any other questions?
Well, actually we don't, because virtually none of us, including ethicists, use logic. And so it's very easy to say palliative sedation is not euthanasia. In logic, it's going to be virtually the same 90% of the time. But because we don't believe in euthanasia and we believe in palliative sedation, we say, well, that's okay. But if you actually use logic, which is the basis of all philosophy, the basis of all ethics, the differences are so much smaller than we like to argue. And so we sit and argue that it's okay to do one, but not the other. I'm not saying that I believe in one or the other, and quite honestly, you know, I don't think any of us know for a given person what we're actually going to believe in. But we should not say we're doing ethics. Ethics requires logic, philosophy, and it should be very clear-cut, and there shouldn't be these gray zones, because the gray zones change with time, you know, and religion changes with time. I mean, the Catholics had a totally different belief when I was in Catholic school to what they have today. I mean, and it just amazes me that people forget this. You know, it changes over time. So it's a very historical thing. What was okay in the 50s is not okay today, and we change. So we have to recognize, I think, deep down, that we're trying to do the very best that we can for people. And we can call it ethics if we like, but it's only ethics when we do it properly. And I missed your first slide, so I apologize.
Yeah, so one of the first third of what I was talking about is trying to just defend this point, or introduce this point, and from Pellegrino, a Catholic physician, that ethics only comes out of the clinical encounter. So that there's this notion of microethics, that there's always this negotiation, figuring out what the values of the patient, putting your own values on the table too, whether or not you make them audible to the patient, but realizing that we're trying to help the patient construct their values, make sense of their values, and that's an ethical task as well. Not merely A versus B, not imposing logic, but rather it's more infinitesimal. I mean, even how you relate to a patient, how you sit, kind of tone of voice that you use, that needs to be negotiated, I think, from a moral standpoint.
In sociology, it's called grounded theory.
I just think when we call it ethics, we're talking about something totally different. Ethics should be very logical and stay that way. I think we're talking about the care of dying people, which I think what you're saying is exactly what most of us do, and we follow through within our own beliefs and the beliefs of our society. But that's not necessarily ethics, and we claim it's ethics. I mean, I sat next to a wonderful ethicist, very famous on the plane journey once, and he said to me, well, at the age of 70, we should kill all old people because we can't afford them. And he was a very famous ethicist.
Is this
Everybody
Peter Singer?
believed in him.
Were you sitting next to Peter Singer?
No, but it was one of the others. There are a number of them
Zeke
that believed
Emanuel
this.
is one of
And
the
you know,
most
in the end, I
obnoxious-
said, how old are you? And he said he was 55 at the time. And I said, that's fine. I hope that you have a heart attack because I'm not going to resuscitate you now because I've decided 55 is a good time not to resuscitate. I mean, but he was, you know, on the news all the time for ethics and stuff like that. And I think ethicists have lost the ability to understand what ethics is. And it's very different from patient care and the decisions we're making. I mean...
So I think you actually made the case for
Nowhere
me.
on-
Yeah, I mean,
This
to
is
some
what
extent, I
Dr.
agree.
Morley is saying, but he can't find the right words. So
Thank you, Mary.
I will help him. Throughout this entire discussion, I didn't once hear the word empathy.
Well, I think that's part of it.
That might be all of it.
I don't think it's all of it. I really don't.
I mean, there's some legal barriers as well when we practice medicine. I mean, you know, you can believe as much as you like in Missouri in euthanasia, but you can't do it. So if ethically you believe euthanasia was okay, which I don't necessarily believe, nevertheless, I could not do it in Missouri unless I was prepared to be seen as a murderer.
You know, call it quality improvement.
I mean, it's the same ethics as believing that abortion is wrong, but killing somebody who killed somebody else is right. You're killing people, there's no ethics in that, that's a religious belief. You've got to believe that both are wrong. If killing somebody is wrong, you can't believe that killing the other person is wrong. That's ethics as a logic, if you want to take it in a simple way. Illogical ethics is usually religion, quite honestly, and we have to learn to deal with it. We live in a religious sphere here, and we have to practice to some extent within the religious beliefs of our institution. I mean, that's how I see it anyhow. I don't think I can practice out.
I just wouldn't equate ethics with legal. I mean, that's why I didn't even address the legal necessarily. Unfortunately, though, our practice is dictated by the legal. So.
There are lots of things.
All right, thank you.
Hey!
Oh, really?
If we smack down a logical precision, we can get and bad things happen.
Cookies everybody. Better with you than with me. My dog is now.
It's just putting, you know, you've got to pick beyond the RCS. Yes, those are local things.
We had 2 minutes.